So if we could ask Dr. Asa, right, followed by Dr. Wolin, followed by Dr. Liu.
I'll start by just mentioning that I had an awful lot of questions about KI67, and I'm happy to answer those with anybody who would like to see me about them. I'd like to pull out two questions that I think were particularly relevant. Dr. Singh, are you in the room? No. Simran Singh. Oh, he's left. Okay, well then I will ask the question, and whoever would like to answer it can volunteer. Is there any, actually, Dr. Warner, are you still here? Maybe you could answer this, because I think somebody also asked you the same question. Any evidence that somatostatin analogs are helpful for people with recurrent disease post-resection, or is there any other drug treatment for patients post-resection? It's a very big question. I think you can summarize that for us very well.
If I understand correctly, you're asking are the somatostatin analogs useful for patients following surgery, resecting their tumors? What was the other?
Or are there any other drugs? So, I mean, it's obviously a very large topic. I don't think you should go into all the other drugs, but I think the clarification is around the role of surgery and medical therapy in sequence or together.
I think, especially in light of the results of the PROMED study, if we can extrapolate a little bit, the answer is a resounding yes. Definitely of benefit, and it's my continuing practice to use the drugs of this type for that purpose. The statistics have not accumulated to satisfy an answer statistically, but the anecdotal observations, which have gone on for many years preceding the publication of the PROMED study, was such that I feel strongly convinced of the use of these drugs for that purpose.
Thank you. Yes?
If I may, it's our experience, and I'd like to hear Rod's observation too, because he takes primaries out of known mets, that oftentimes if there is relevant metastasis in the liver in a midgut carcinoid, the removal of the primary almost unmasks the beast a little bit more. The symptoms become more prominent after surgery, and that would certainly be, in the old literature and the surgical literature with neuroendocrine tumor surgery, was that they didn't like to do it before sandostatin because it seemed to make things worse. At least at Ohio State, that was their experience. The other thing is, I think, when you have Artria scans that are positive in the liver, and it's just what Dr. Warner said, in addition to the PROMED study, it just makes total sense. There's over 415 papers now on the anti-proliferative effect of octreotide acetate, and it's just never made sense to me that it should be in perpetuity, from my view.
The next question is again reflective of two or three people's questions about the value of being treated with, or the impact of being treated with octreotide, and the questions were around how is the chromogranin A value affected, and I expect the value would be suppressed, and also is there any indication of other impact on measurements of other net activity? And I guess I'm going to ask you to answer that question because Dr. Singh is not in the room and it was addressed to him, but I think... So what is the impact of treatment with octreotide, or imagine any of the other somatostatin analogs? How does it impact chromogranin A values and other values of neuroendocrine tumor activity?
Well, the short answer is it very commonly makes the values go down. It impedes secretion of various peptides and amines by the neuroendocrine cells, and that's one of its mechanisms of action. So if somebody has a higher level in the blood before and a lower level after, it doesn't necessarily mean that the tumor has gotten smaller. It means it's making less. And that's why it's extremely useful in controlling the syndrome caused by hormone secretion, as well as the effect that Dr. Warner was alluding to in controlling tumor growth.
And I don't know if Joy Ardell is here or not.
Yeah, she's standing at the other microphone.
Go ahead, Joy.
Yes, I was going to say that I'm going to be speaking after lunch, and also Tony Heaney will be speaking then, and I think we'll be showing quite a lot of data about how the blood circulating markers respond to various treatments. So stay in and watch that, and you'll see it on pictorially.
Great.
The chromogranin A certainly does come down to somatostatin analogues, so do the other markers. Not right into the normal range often, but they do come down.
Okay, I have a question that as patients, we can choose our doctors, but not our pathologist or radiologist. How can we control for that? Well, first of all, I don't want to make a distinction between clinical doctors and pathologists, since pathologists are equally doctors as well, even though they're practicing a different specialty. The second thing is that microscope slides and the paraffin blocks that microscope slides are made out are very readily transported from one place to another. They could be mailed, they could be delivered in all sorts of ways. And it's a very simple matter to have a second opinion about pathology. We do this type of thing all the time. And if patients are feeling uncomfortable for some reason with the local pathologist, or the slides have never been seen by a specialist, by all means talk to the local pathology department about having the slides sent to a pathologist who's a specialist. Any other thoughts from pathology?
No, I have nothing to add. I would encourage you, if that is a concern, to ask for a second opinion. There's no reason in the world why you can't.
Right. And the other thing I should tell you is that when you seek an opinion from a center of excellence, a multidisciplinary, specialized center, really every one of those centers I could think of in the country, if not in the world, has a very close working relationship with very experienced neuroendocrine pathologists. And I think that's always the first place to start. And I think the same would go for the question about radiologists.
Well, I think also, like in Canada, if you're being seen at a regional cancer center, you are already into a stream in which the cancer center would be reviewing pathology, and you have the expertise of the radiologist. So all of our regional cancer centers have some mechanism of making sure that the experts are looking at it.
Okay, and then the next question I have is, how would a Canadian patient access a referral to your hospital? And that's a question that I think would have to do with the National Health Service of Canada and some local policies. I think really any patient in Canada or anywhere can have access to any medical facility for a second opinion, but it's just a question of whether they would have payment for that provided by the Canadian government, and that's really an internal question that I don't have an answer to. But I think that we certainly see patients from all over the world who come and want a second opinion. But I think what the internal policies are, I don't know. From what we've heard so far in this conference, there certainly are many centers of excellence in Canada with specialized care, but I think that international referrals I can't make any comment on, and there might be somebody from Canada who would be able to respond properly to that.
I'll just make a comment that I think it's very difficult for Canadian patients to be sent out of country unless there's evidence that the therapy cannot be provided in Canada. And I think Maureen's just gone to the microphone, so I'll let her say more.
Yeah. Personally, I didn't have a problem getting a second opinion in Canada, but I know that the two centres of excellence or expertise in London and Calgary may be very different. There's a lot I don't know. There's so much we have to learn in CNETS Canada. But I did know that as of March 2009, patients could not go to London anymore. That was the centre in Eastern Canada. London was particularly good because of the nuclear med capability and the ability to send patients out of country for lutetium and yttrium. And right now it's unclear as to who else can be sent out of country, though I think BC sends people to Sweden. I know people from BC are sent to Sweden, but I don't know from what the organization is prior to that. I don't know about Nova Scotia, I don't know about Prince Edward Island, I don't know about most of the Canadian provinces. So we have a lot of, once we have more discussion, we'll understand better what the pattern of referral might be, both to centres of excellence within the country or centres of expertise and referrals out of country. There's just a lot of clouds around it at the moment. Thank you.
I too had many questions we're not going to be able to answer today, but we'll ask one bread and butter surgical question and one maybe more philosophical question. So for the surgical oncologists here on the table, if we could talk about, we'll combine two questions. After surgical resection of the liver, can you go back in? And if someone has metastases of the liver, how big must it be seen by laparoscopy and to be removed?
Well, yeah, the answer is absolutely. Our first choice for any recurrence is always surgical. So that's the first level of therapy, is to see, can it be resected again? And it often can be. And I think Janice and I are of one accord. These little metastases are frequent. I completely agree with what she's reported. I often go in to do a mesenteric resection or something on someone who had a small bowel obstruction with a carcinoid primary. The other surgeon, as she said earlier today, was a wise surgeon, did not want to take on the mesenteric resection, but I'm told there are no liver metastases. It's clean. And it's like, well, we get in there, and I find these little freckles, and there's no tumor that's too small to try to either remove or burn out or take out in some way.
The second question I think is interesting. Broadly, I think it applies to really everyone at this table. It says here, what steps are being taken to educate surgeons and other GPs and specialists about neuroendocrine tumors? Whose responsibility is it to update information for existing doctors?
Well, I think from the certainly in the surgical medical oncology type endocrinology group in Canada, there's been many steps to try to broaden that at local, provincial, and national meetings, and it takes a lot of pushing and the advocacy of the physicians to get onto the program of session on neuroendocrine tumors. And so we've been successful at the Canadian Association of General Surgeons to have had several symposiums on endocrine surgery. The same at the SSO, getting a panel on endocrine surgery. It's one room out of 5 days of meetings for surgical oncologists, but it just continues to be something that has to be pushed from the physicians that are taking care of it. And it is happening slowly. Also, all of these centers, these centers, as we train more surgeons and medical oncologists and internists, they go out and they start working at their center, and it really is passing on the expertise that they learn at the university centers to the smaller centers, and this is going across the country as we have fellowship programs in surgical oncology, endocrine surgery, and the same in medical oncology. So you have to be somewhat patient, but it's slowly coming, certainly in this country.
Yeah, I want to comment on that too because, I live in Tennessee, which is a mildly rural area, to say the least. And I consider it my job to get out there and to really beat the bush and to tell these people that it's okay if you don't know how to take care of them. Just send them to me and we can provide the best care possible for that patient, because frequently they'll come to me. I have to take care of peritoneal carcinomatosis as well too, and a lot of people are just left to linger. And so just by, I consider it partially my responsibility. But what I discovered too, it's partially the responsibility of the patient. The patients, now the internet is so powerful, they will go and they will find me or whoever their other local specialist is, and then they will go back and talk to their physician. And I have long conversations by telephone with their physician. So I think it's pretty much everyone's responsibility. Anyone who's interested in family. I've actually brought my nurse practitioner, Charlene Chase, here because she offers expertise, but it's also an opportunity for her to learn as well. So really, if we can all be involved, we can tell people that the zebra really exists and it's not as rare as we all think it is.
I'd like to reemphasize that it is everybody's role to play here, and I just want to make a comment about what you said. It's fine for those of us who are here, who are in the field, to go out and tell docs about it, but to some extent our colleagues see that as being a form of self-advancement or hype or advertising. So it puts us in a very difficult situation. One of the fundamental problems is that kids are still taught in medical school that these are rare diseases, and they're kind of they go through their training thinking, well, I'll never see one of these. And that's why it's missed so often. So it really does help a lot to have the public and to have patients and to have other people really kind of lobbying to make this fallacy of the rareness of the disease go away so people really learn about it.
Thank you. So if I could get those questions from the three of you, please, so we can honor our commitment to you. This officially concludes our morning session.